If I'm thinking about healthcare from the perspective of medical health disparities and inequity, I think the state of California legislation around Knox-Keene, which is a it's a HMO managed care framework, which was created in the 1970s, which establishes geographic barriers that are adequate to patient care, is the biggest opportunity to solve health disparity and equity. So currently, there's these sort of requirements in place called HEDIS and quality measure scores, and patients have to basically receive these high-level scores to support their patient population. With the Knox-Keene, they've established a framework for advanced care to be 15 miles from the patient's home. So what that inadvertently does is it makes these health systems kind of sit at 15-mile radius from the poorest areas of California. So certain counties have these very kind of healthcare deserts. There's not a lot of providers. And a lot of it is the policy around pricing. I mean, the state of California, they could look at Knox-Keene reform, which would basically maybe tighten that window from 15 miles to 10 miles. You could also look at managed care laws, which are maybe more nonprofit focused. So you can kind of encourage reinvestment into the area. And then on the federal side, I think HIPAA causes a lot of harm. I mean, if you think about the HIPAA law, which is created it's basically talked about to protect patient confidentiality. But what it's doing a lot of it is keeping all this information confidential. So you don't really know what things cost in healthcare. You don't know how things operate in healthcare. I think HIPAA could be reformed, possibly, to allow more transparency. If you look at healthcare IT, you can look at reforming high-tech information laws. The way medical information is shared from one to the other is sort of monetized. So I think there's a way you can support, interoperability in healthcare exchange. You can look at sort of eliminating the ability for IT vendors to collect fees to share information. I mentioned Knox-Keene. If you reform Knox-Keene, that would allow for geographic expansion. On the provider side, you can pay more money for hardship posts. So right now, providers might get 60% of Medicare to 80% of Medicare for payment. And in affluent markets, you might get 300% to 800% in academic centers in affluent market areas.